Hello, everybody. Welcome back. It is my pleasure to introduce Dr. Jenna Wiens, who's going to be kicking off our final talk session before we go into the panel. Dr. Wiens currently heads the MLD3 research group and is the co-director of precision health at the University of Michigan. Her primary research interests lie at the intersection of machine learning, data mining, and healthcare. For several years now, Professor Wiens has been focused on developing accurate patient risk stratification approaches that leverage spatiotemporal data with the ultimate goal of reducing the rate of healthcare-associated infections among patients admitted to hospitals in the US. I'm excited to see how her team is applying what she does to develop the Michigan COVID-19 utilization and risk evaluation system to improve clinical care, especially during hospitalization surges. So please welcome Dr. Wiens.
Great, thank you so much for the invitation to come and speak with you all today. So I'll be talking about an ML approach, a machine learning approach to predicting complications in patients with COVID-19. And as Emily mentioned, I'm an associate professor in computer science and engineering. I sit in the artificial intelligence lab, and I co-direct precision health at Michigan. So in hospitals today, we're collecting just an immense amount of data about our patients. Everything from what medications a patient is taking, to where a patient is in a hospital, to data from imaging and clinical notes. And in my research group, we develop and we use machine learning techniques that can detect patterns in all these data, patterns that can help us sort patients from low risk to high risk for a particular adverse event or bad outcome, or help us match patients to appropriate treatments with the ultimate goal of augmenting clinical practice and improving patient outcomes and patient care. Given the challenges that today's healthcare system is facing, there's a critical need for such clinical decision support systems. So in my group, we develop and use machine learning techniques across a number of different healthcare settings. So from diagnosing and predicting risk of healthcare associated infections to modeling risk and the progression of long-term diseases like Alzheimer's disease, to more acute diseases like graft versus host disease or shock in the hospital. We also look at matching patients to treatments, so patients who have sepsis or acute respiratory failure, or patients with diabetes. And in all of these projects, we work really closely with our clinical collaborators who help guide us and keep us on track and make sure that we're solving problems that really matter to them, to their patients, and to society. So given the theme today, I'm going to be telling you about some of the work that we started just over a year ago at the start of the pandemic on COVID-19. So back in early March of 2020, the first few cases of COVID-19 in the state of Michigan were recognized. And by late March, March 21st, March 24th, our capacity to test greatly improved, and the number of cases quickly rose. And though Michigan medicine started with just a handful of cases without intervention, it expected that the number of cases, the number of admitted patients with COVID-19 would increase exponentially in the coming days. And this exponential increase, combined with a potential shortage of resources, led to tough questions. So here at Michigan, hospital leadership began to explore converting an indoor track into a field hospital to meet demand, to be able to care for more patients. And around this time, members of the AI labs, the artificial intelligence lab, partnered with members of Michigan Medicine and the Institute of Health Policy Innovation to develop clinician decision support tools that could help with this. So specifically tools that could help identify patients at greatest risk of complications or adverse outcomes from the disease. So for example, who might need respiratory support, like a mechanical ventilator, who might need cardiovascular support, like IV vasopressors, or who might die in the hospital from the disease. And such a predictive model could help clinicians in the hospital manage a surge in COVID-19 patients and anticipate needs well in advance. So Michigan Medicine expected a surge in April, so they contacted us in March and wanted a model. And given that along with the rest of the world, we knew little about the disease and potential risk factors, we took a data-centric approach to the problem, leveraging the contents of the electronic health record. And this is an approach that we take often in our group for modeling different outcomes. Within the electronic health record, we have everything from what medications a patient has taken to frequently measured vital signs like heart rate. And using these data, we learn a mapping from the EHR data to an estimate of the patient risk of experiencing complications from COVID-19. So the score that we developed, or the model that we developed, we call MCURE. So this is the Michigan COVID-19 Utilization and Risk Evaluation System. And it repeatedly assesses the risk of a patient over time. As more information comes online, as the vitals signs of a patient change, as labs come back, all that information is used to update the risk of the patient over time. And we make predictions at every 4 hours during the visit. So from a machine learning for healthcare perspective, we encountered numerous challenges. So including the fact that cases were rapidly increasing, there was a lot of pressure. There was relatively little training data from which to learn. So even though we had this influx of cases, the techniques that we use, machine learning techniques in high dimensional spaces, rely on a lot of data. And there were few enough cases that we really needed to hold all of those aside for testing purposes. We couldn't afford to use any of them during training. So what we ended up doing was training on not a COVID-19 cohort, but a related cohort of patients from previous years that had presented in the emergency department with similar symptoms. So this gave us a data set of approximately 20,000 patients to train the model. Then the next challenge we faced was the small number of cases on which to validate. So we had the COVID-19 patients held aside as a test set, but we had not only limited cases, but also a limited timeline. We were expecting a surge in a couple of weeks. Typically, when we train these models, it could take months, if not a year, to train the model and retrospectively validate the model. And then we might prospectively validate the model for about a year before we show it to any clinician, and we just didn't have that time. So in light of that, we scrutinized the model. So we scrutinized the model, meaning we looked at what the model had learned. We opened it up and we checked every single variable and made sure that it aligned with clinical intuition. There was no label leakage or spurious correlations that the model was capitalizing on. And then finally, though we started with thousands of variables in an effort to produce a model that could serve not only Michigan Medicine, but other hospitals across the US and across the world, we aimed to reduce the model to a subset of readily available data in the EHR. So our approach, we started by not making any assumptions and throwing everything into the model. And then we scrutinized it and got it down to a small set of variables that were readily available, or that we believe to be readily available at other institutions. So things like vital signs like heart rate that you would have almost anywhere, so that the model could transfer. So our test cohort consisted of all adult admissions between January and July 2020. This is really March 2020 to July 2020, since we also are looking at only those patients who had a positive diagnosis of COVID-19 and who had received supplemental oxygen. Our outcome, so of the patients that met our inclusion criteria, we want to be able to predict a composite outcome. So in hospital mortality, who's going to die during the current hospital stay, who's going to require invasive mechanical ventilation or heated high flow nasal cannula, or the receipt of intravenous vasopressors. And these are all proxies for ICU level care or more complex cases that might need more attention. And the way that our risk model works is that from the time of the first vital measurement, we count in 4-hour segments. So we at 9 a.m., 1 p.m., 5 p.m., and so on, every 4 hours, make a prediction of that patient's risk based on the data that we have up to that point. And we delay our first prediction until we have full 4 hours worth of data. So the first vital measurement might happen here. We wait until we have a full 4-hour window, and then we go ahead and we make our prediction. And we pick these times since they correspond to peak times when the clinical care teams would round and collect data and make decisions. And during our testing, we excluded individuals who met the outcome prior to the first prediction time, since at that point the predictions moved. So we evaluated the model's predictions on a held out test cohort of over 200 patients. In particular, advised by clinicians in the hospital, we focused on 2 use cases. The first use case aims to identify individuals who are experiencing the adverse outcome early after admission. So the goal here is, can we identify those high-risk cases? So those cases that are going to experience the complications or composite outcome within the first 5 days of admission. And in our COVID-19 test cohort of 278 patients, close to 30% met that criteria. The MCARES model applied to this cohort achieved an area under the curve of 0.8. So this is a measure of the discriminative performance of the model. And if we threshold it, we get a sensitivity of close to 50%, meaning we correctly identify 50% of the complex cases or high-risk cases as high risk, with a positive predictive value of 65%. So the majority of the cases that we're calling high risk are in fact high risk. And we compared the performance of the model we developed on patients at Michigan Medicine for patients at Michigan Medicine to a proprietary model developed by Epic. So Epic is a provider for the electronic health record system at our institution and many other institutions across the US. And they have a deterioration index. So this is the Epic DI model that comes with a lot of the Epic builds. And at the time, early on in the pandemic, a lot of hospitals were considering using this deterioration index to help triage patients and manage their resources. However, when we validated it on this test cohort, we found that it performed significantly worse than the model we had developed. So at the same positive predictive value, it identified only 7.5% of the cases, in contrast to our model that identified nearly 50% of the cases. So based on the feedback that we received from clinicians, we also explored a second use case. In addition to identifying who was at highest risk, we identified who was at lowest risk. So how well does the model do at predicting who is unlikely to deteriorate during the remainder of the admission. So what cases will not become complex? These might be good candidates for a field hospital or good candidates for care at home. So after applying our exclusion criteria here, we had a test cohort of 210 individuals. So these are patients who are still in the hospital at 48 hours and have not yet met the outcome. And we're asking, are they unlikely to meet the outcome for the rest of the visit? And 78% of the patients don't meet the outcome for the rest of the visit. And MCures, our model, flagged 19% of the population as low risk with 0 false positives, meaning that of the patients they identified as the model identified as low risk, no one went on to suffer complications. It didn't make any mistakes. Now, if we want the same high bar for the EPIC deterioration index, 0 false positives, we can only flag 1.4% as low risk. So this shows the benefit and the utility of a model trained on this specific population for this specific outcome compared to a proprietary model that was not designed for this use case. So at the same time that we were working on this model, the governor implemented a stay-at-home order. And fortunately, the curve at Michigan Medicine and Michigan in general flattened, and we didn't have to open the field hospital, and clinicians didn't have to turn to using MCures. But that didn't mean that we stopped working on it. We're still working on MCures. We've now validated the model on over 700 COVID-19 individuals or patients at Michigan Medicine. We have also worked to integrate it into the electronic health record system. So it's running in the background right now in silent mode. So for every patient that comes in, it's COVID-19 positive, it's making a prediction every 4 hours. And we have those predictions and we're storing them, and pretty soon we're going to look at how well that model does prospectively. We're also working with other institutions to validate the model in their patient populations. And preliminary results look very promising. And I'll just end by highlighting that this was a real interdisciplinary effort with many, many students, clinical collaborators from Precision Health, the data office, the research data warehouse, MyChart, and external collaborators all working together, yet remotely. Thank you.
Excellent. Thank you for sharing this. To the attendees, go ahead and put any questions you have in the Q&A. I have a question to start out with. So, there's been a lot of attention paid to the fact that the age structure of the pandemic has been changing, partly because of vaccination, I think partly because of the virus moving into new populations. What does that mean for your model? Yeah, can you comment on that?
Yeah, that's an excellent question, and something that came up in September, even when we were starting to see a shift in the demographics, and we're anticipating a second surge with a younger patient population. And we were, in advance, we started to look at, well, how does this model perform across different age groups? Because it was selected and validated on COVID-19 patients that we saw early on during the pandemic, which was an older population. We were concerned that the model might not generalize to younger population. What we found was actually the opposite. It does really well in the younger population. Those are actually easier cases for it to be able to rank or compare compared to the older patients. So we did that across age groups. We did that across races. We did that across sexes. And now we're looking at across institutions as well, testing the generalizability of this model, since we would like to release it and make it open source so that everyone has access to it. But we want to make sure that it will work.
And could you say a little bit more, this is a question from the audience, could you say a little bit more about which machine learning techniques in the methods?
Yeah, absolutely. So we were looking at mostly simple linear models. So we ultimately ended up relying on machine learning techniques that we had previously developed for predicting C. diff infections. So because we have a rolling risk over time, it accounts for changes over time as well. So we have published the approach previously in the Journal of Machine Learning Research back in 2015 in a different context. And now this was an opportunity to apply it for a different outcome and a different problem.
Excellent. And then one last quick, actually, you know what? There's one more question for the audience. I'm going to save it for the panel because I actually think it's a question that we can, about long COVID, that we can apply in a couple of different scenarios. So thank you again. And I will see you again at the panel.